Okay, thank you very much for the opportunity to be able to talk a little bit about COVID treatment and QT prolongation, and for consideration when, as patients who may have long QT, if they are affected by COVID, or even family members are affected by COVID, what are the implications? And I'm actually glad Dr. Ackerman is here, because over the last several months, he has published several guidelines at the Mayo regarding considerations for patients affected by COVID and management within a large healthcare system. And we'll have some of the slides representing some of the algorithms that were developed by Dr. Ackerman's group. Disclosures: I do have research grant funding from Medtronic, Biotronic, and Spire Health. That should not impact today's discussion. So with SARS-CoV-2, the COVID-19 virus itself, as most of us know, the pandemic has affected all parts of the United States as well as the world. And when we start looking at how do the patients present, initially we knew, for example, New York City, which is only a few hours drive from Rochester, New York, right in our backyard, had a significant number of patients affected by COVID, admitted, high mortality, as well as an opportunity to overwhelm the whole system of healthcare in New York City. And this has happened around in city after city. And during that early spring time pandemic, with the first surge, several researchers in multiple communities were able to gather data very quickly. And along the way, several different options for treatments were being explored with limited evidence at the time. The anti-malarial drugs, as well, that were used in many parts of the world to treat malaria for over 70 or 80 years, showed some success in a specific subgroup of patients. Additional drugs like, for example, antibiotics, were added to the mix as adjunct therapies to enhance the effect, try to work on the mechanisms in which the virus will go ahead and go in the cell and start affecting the person. And along the way, some of these drugs had the potential to prolong the QT on their own and have been reported to do that. So now all of a sudden, the question was, what is the risk of having the QT prolonged, drug-acquired QT? And what is the risk if someone already has a congenital form of QT prolongation and needs one of these treatments if they're affected by COVID? So if we go back and start looking at large studies, for example, 5,700 patients in the New York City area, which has multiple hospitals, they looked at those patients and comorbidities, what's associated with a COVID-19 infection, that they saw what made patients at higher risk. It was hypertension, their BMI, obesity, and diabetes played key roles. We know, for example, patients that showed up to the hospital with any kind of respiratory symptom, about 14% of those needed to go into the intensive care unit. And the vast majority of those, 12% of the total group that showed up to the hospital, required mechanical ventilation on a ventilator. And unfortunately, at the very early stages of the surge, it was the experience with managing these patients, the limited number of drugs and methods to manage the disease was still in the early stages, and the mortality rate in this particular group was 21%. Interesting that they noted that about 6% of the patients showed up with a baseline QTc of over 500 milliseconds. And almost everybody in the symposium today knows that 500 is this number that's been around for decades, that showed that risks associated with QTc greater than 500 for developing torsade or in a cardiac event is increased in that subgroup. Now, this is when we get data, especially very rapid data that gets published, we always have to take into consideration what the study was for and what it meant to do. And in this group, they wanted to look at outcomes, but also just collected all the data. And it looks like most of these QT data may have been electronic acquisition, not manual reads like we do in the long QT trials that are very specific for research studies on QT prolongation. But here you still had a significant number of patients show up already. And subsequent studies, and I'm not going to go through those, showed that most patients, almost all patients that have COVID, do not prolong the QT. And I think that's one of the emphasis I'm going to make along the way. And I think Dr. Ackerman can also chime in that having a long QT does not increase your risk of acquiring COVID itself and being infected by COVID, and does not change your outcome related to the COVID disease itself. But what there are considerations that need to be taken that depends on the medication or the pharmacologic treatment you're going to potentially receive. And early on, this was a concern because of the drug hydroxychloroquine that everyone here has probably heard about either through the news or through Twitter or a few other venues. Well, the COVID-19 virus has several mechanisms in which it can actually alter the cell function. One of them is that the virus does use the angiotensin converting enzyme to the ACE2 protein for entry into cells themselves, and starts a cascade of events that can end up leading to a significant inflammatory reaction subsequent. And the ACE2 protein is also the protein that's very heavily seen in lung, distributed in lung, as well as other parts of the body, including the heart. We know that a subgroup of patients develop myocardial injury itself. So if you measure the blood, they notice that there's troponin and other factors that show that the heart has been damaged. Sometimes it's very subtle. Sometimes it's significant enough to cause shock and drop in ejection fraction. And this we know is part of that, but it does not directly affect the proteins and the ion channels involved in long QT. So I wanted to emphasize again that long LQTS patients are not at greater risk of contracting COVID-19, and there is no associated change in outcomes from the disease itself. But the treatment itself requires some consideration. And this is just a graph that was obtained. This is from the European Society of Cardiology guidelines for managing cardiovascular disease. And one thing we all hear about COVID-19 and cardiovascular disease, and I want to just emphasize that cardiovascular disease covers everything, not just long QT. It can cover heart failure. It can cover myocarditis, inflammation of the heart. It can also cover other rhythms like atrial fibrillation. That is a very different rhythm than the life-threatening rhythms that can occur associated with sudden death. A lot has been learned in 8 months of the COVID pandemic. We're now in the United States is now in its second surge. We are, for example, not plateaued yet. We're still going exponential here in Rochester, New York, and we were spared a bit in the first surge because we are about 300 miles north of New York City. But throughout the country, we've learned a lot about different therapies. If many will recall that there were different news items, hydroxychloroquine, which was an anti-malarial to treat malaria in large parts of Africa, as well as the addition of antibiotic, the Z-Pak, that many people would be associated with, familiar with it, is the azithromycin. These drugs were repurposed to be used and were found to improve to some extent in a group of patients the outcomes in COVID-19. This was very early in March and April. And one of the things that that ended up causing a concern was the QT prolongation that's been associated with the anti-malarials, as well as azithromycin when it was added on. And several discussions, as well as guidelines, were being discussed. It was some hospitals were using it, some other hospitals were not using it yet, and there was the evidence for it was limited, but it was a fairly high mortality disease. So these applications were being done, and I'm going to go into a little bit about how to manage this. Steroids, dexamethasone, and other immunosuppressive agents were tried, and there is some data that dexamethasone is effective in a certain stage of the disease. In terms of the antivirals, the most effective so far to date that has a lot of evidence with it is remdesivir, and it's actually commonly used now as standard of care with some limited evidence, but now has become a standard of care for treatment, at least today. When we talk about antibody-mediated effects, convalescent plasma. So this is the plasma obtained from patients who have recovered that have antibodies that can help mitigate and reduce some of the effects of the active infection in patients who are sick. And of course, right now, there are 3 different vaccines that will be distributed throughout the United States in the next several weeks. And that may or may not, and I put the remdesivir here, I should have had the vaccine names here, but it's not meant necessarily to replace remdesivir. Vaccines are for long-term prevention. So by vaccinating a population, less people will end up with the severe form of the disease, and then you have a decrease in number of people exposed to it and a reduced number of infections overall. And that there are 3 different ones, very different kinds of vaccines, and they will be distributed throughout the United States. So the treatment has changed a lot, and it's still only a handful of months since we've learned how to manage patients. Hydroxychloroquine, which is something that is associated with QT prolongation, was found not necessarily to alter mortality within 28 days. This was published in the New England Journal of Medicine. And therefore, it's not really the standard of care anymore to mortality. Some sites may be using it in a specific subgroup of patients that may for prophylaxis or other. But right now, it is not the standard of care, and remdesivir has replaced the hydroxychloroquine to a large extent. Dexamethasone, because of the inflammation that's caused by the COVID virus, including that it can affect the heart as well as in multiple organs. The inflammation caused a study published in the New England Journal of Medicine showed that dexamethasone, which is a powerful immunosuppressive agent, was able to, in patients who require mechanical ventilation, was able to have a very significant improvement in all-cause mortality at 28 days. So patients to the left of the chart, if we look here, less than, it means that dexamethasone treatment was better. And if patients were pretty healthy, did not require oxygen, did not require being on a ventilator, then there wasn't much difference in there. What didn't do any harm, but it didn't do any good in that subgroup. So for the sicker patients, they did better if they got some immunosuppression or to reduce the inflammation that's caused by the drug itself, by the virus itself. The remdesivir that's actually active now in almost every hospital in the United States treating was tested, and the results were recently published. It was a double-blind, randomized, and placebo-controlled trial, which means some patients got an injection of placebo, saline, or something that it was not drug, and received remdesivir in the other arm. And these patients had to present to the hospital with a lower respiratory tract infection. So it's not just sniffles, they had to have lung disease. And they were randomized, over 1,000 patients were randomized to receive remdesivir or receive just placebo. And the median time to recovery was shorter. And the primary endpoint was how long to recovery. And they had a scale of 1 to 8. And if you were able to get off oxygen, go home, you were considered recovered. And the median time was a lot shorter. You can cut recovery from 15 days down to 10 days. There was also, as a secondary, there was definitely some improvement in reduction in mortality on drug versus not drug. And the basis of this study was what is used now for people being treated with remdesivir. So right now, remdesivir itself has not been associated with QT prolongation, even though we have a case here that there were polypharmacy played a role. And right after remdesivir, there could be somebody who had Torsades, but they also had other QT prolonging drugs on board. But the role of polypharmacy, multiple medications being treated in a very critical condition, increases the risk of Torsades, despite people not having long QT. And if you do have long QT syndrome, then the risks are higher. This whole consideration needs to be taken, that and an understanding, and the healthcare teams are learning and should know that the risk of the drug can be amplified by using other drugs that prolong the QT. And correcting these factors that contribute to QT prolongation low potassium levels, low magnesium levels, low calcium levels that can contribute to having life-threatening rhythms. Another thing that's important is people worry about the COVID drugs themselves to treat COVID as prolonging QT. There's only a couple of them, which was the older ones we talked about, the hydroxychloroquine. But there's also plenty of other drugs that prolong the QT. And in an ICU setting or an acute hospital setting, drugs keep adding. And these can be the sedative drugs, these drugs that are used, for example, quetiapine, Haldol, that potentially prolong the QT, that are just used to keep people calm while they're being treated on a ventilator, and may also, and drugs used to treat other rhythms like atrial fibrillation. And this is from Dr. Ackerman's group, where they actually published an article on guidance for navigating the QT prolongation and the risk of life-threatening arrhythmias in patients with coronavirus. And one of the key things is this takes a lot of what is modifiable risk factors. These are risk factors that we as healthcare providers, as well as patients and families, can be actively involved in reducing electrolyte disturbances. Healthcare providers knowing and taking measurements to make sure your potassium, calcium, and magnesium levels are maintained. And the other thing is that the QT prolongation, any medications that may prolong the QT, people are aware of it, and we're all familiar with Credible Meds. There's apps. We use it all the time here at the Med Center, and people are aware of it. And it's been one of the key things that helps healthcare providers and the teams, the health system, have a better idea of what medications patients are on. When we look at the other side of this graph on non-modifiable risk factors, like you've had a heart attack, there's already existing heart failure, starvation or anorexia plays a role with electrolyte imbalances and other factors, very slow heart rates at baseline, congenital long QT or other genetic predisposition to having arrhythmias, kidney failure, that people are on dialysis, difficult to control electrolytes there, diabetes, hypoglycemia, and a personal history of QT prolongation or sudden unexplained death when there is no diagnosis, just having that history, the elderly, and women. So those are not modifiable risks, but those are risk factors we all need to consider when starting medication. And this is a snapshot from the Mayo Clinic proceedings of Dr. Ackerman. And while the left slide is very detailed, it was a very good practical approach that allows a healthcare system to look at patients and very quickly, we know, for example, that 90% of the patients are low risks, considered low risk by having a QTc less than 470 for males and less than 480 for females. 90% are low risk. And they are going to get potentially QT prolonging drugs for COVID. And this was at a time too where we were considering hydroxychloroquine as the primary agent, and it had QT prolongation associated with it. So there was this green, low risk. Then you have the moderate, the risk in between, where only about 9% of the patients would be there. It's not a small number, but it is something to be aware of. But the highest risk was that 1%. And while it's a small 1%, it's a real 1% when you talk about potentially hundreds of thousands of people being affected. And so there are algorithms in place that would apply for this pandemic, but will probably also play a role for any future large-scale pandemic or other disease pattern that requires the giving of drug and administration of drugs that prolong the QT. So what can we do to protect ourselves? Whether patients with LQTS and family members, whether they have LQTS or not, are not at high risk of contracting the virus, and the disease due to virus progression itself does not decrease the benefit, where it doesn't decrease the outcomes or worsen outcomes in patients with long QT. But drug therapy is where the key risk occurs. But just like everybody, we always recommend make sure that you take your flu vaccine, manage those underlying what we call comorbidities, those other diseases associated with poor outcomes in COVID, which is high blood pressure, the BMI at a reasonable range, under 30, and ideally under 25. Masking is the most powerful. Masking and social distancing are the most powerful tools available. And any kind of chronic lung disease, whether it's emphysema or asthma, needs to be managed well in compliance with all the medicines that are prescribed. These things alone will help reduce the risk of any worsening of the disease when being treated, and following the usual precautions to notify the healthcare team. Anybody taking care of you in the hospital or a family member in the hospital should know about long QT. This way, they're always thinking when they ask for more medications to be added to the regimen. And it may be not the COVID treatment medications. It'll be something that most people would think is benign, a sedative, a medication to help people sleep better, or an antibiotic for a secondary infection. It's these other things that get overwhelmed, that can overwhelm the decision making in a critical environment. And I'm going to unshare my, thank you, and I'm going to unshare my screen.
Thank you, Spencer. Very nice presentation and great summary. I see that there are two questions about vaccines. One of them is related to the fact whether there's any data on any adverse events specifically related to LKTS. And the second one is whether would you recommend LKTS patients to be vaccinated first as a high-risk subgroup? Should the LKTS patient get it right away?
I think I'm going to share this one with my other panelists, but my impression is from what I've read and the limited data that's been available, because the data's all been published recently in the last 8 weeks for most of the 3 different vaccines, is that there is no direct association with QT prolongation secondary to the vaccine itself. And would I recommend? Right now, the recommendation from the CDC is that everyone get vaccinated at some point in the near future because of the significance of the disease and the spread and the how easily it is spread from one individual to the other and the potential bad effects. There is some evidence that people who take their flu vaccine, that's one of the reasons, may develop secondarily some kind of rev up the immune system to be able to protect them against subsequent infection with COVID or reduce the severity, but that is still has not been proven. I know there's several people, Dr. Ackerman and Dave Wong, and several people on this panel.
And as you mentioned, LKTS by itself does not represent a higher risk unless there are some additional comorbidities like obesity, hypertension, coronary artery disease, COPD. So, but the genetic disorder by itself does not represent a high risk subject. You should get it as a high risk group, unless we're talking about medication interaction. And
I wanted to ask Mike. Mike, based on your best judgment, do you think that all patients with inherited arrhythmia disorders, like long QT, Brugada, and hypertrophic cardiomyopathy, should they be considered as high risk from COVID vaccination perspective?
Thanks, Wojciech. Spencer, thanks a lot. That was a great talk. I don't think we should be thinking of any of our genetic heart disease patients as high risk. And I think that's what we've been saying on SAD's Facebook Live, for example, since mid-February, that long QT patients have the exact same risk profile for SARS-CoV-2 infection that I do if you're my age, or that my daughter does if you're her age. So I don't think our genetic heart disease is predisposed to increased risk. One could potentially argue that in theory, the only one that might would be, say, genetic ARVC, whereas if we had a viral mediated myocarditis superimposed on top of their genetic ARVC substrate, that could potentially be a disease aggressor. But for long QT, Brugada, it's fever, and it's the same issue with any viral infection that produces fever, is we want to lower fever. And the vaccine is going to give a transient fever, it's looking like. So we're going to have to be conscious about fever reduction in Brugada patients. But I really want our long QT families to be confident that you are not at high risk. And therefore, your placement to get the vaccine, you should not be in the front of the line. So I'm not in the front line. So the front of the line is going to be my colleagues in emergency department, in the ICU. They're going to be the front line getting it first. I probably will be second tier at Mayo. And then as it rolls it out to the families, they will get it. Now, if you're eager to get the vaccine, but you have not yet gotten your flu shot, you're not thinking quite correctly, because you need to have gotten your flu shot. So if you have not gotten your flu shot yet, after the seminar is over, go to the handy dandy grocery store and do the drive-through flu vaccine and get your influenza vaccine. That's really important.
Yeah. So again, thank you, Mike. I think this is an important comment. The risk of the patient and those with inherited arrhythmias depends upon the comorbidities, but the inherited arrhythmia by itself does not represent a higher risk.
And like Spencer said, the other thing to add, right, is that to date, I'm not aware of a single vaccine of any entity for any disease that has been QT aggravating. So when you think of our children getting all mumps, measles, rubella, whatever, there has just not been a vaccine that I'm aware of that has been a QT prolonging vaccine. And in addition, like Spencer said, right now, all of the contemporary therapies that are being used for COVID-19, none of those medications, antibodies, medications, so forth, are QT agitating. Only the ones from the very beginning, which almost nobody's using right now. Well, I actually think probably a lot of people are still using hydroxychloroquine out there. Hydroxychloroquine and Zithromax are the only QT dangerous COVID therapies, but we really should be referring to them as COVID therapies because the evidence is pretty clear that they don't work.
And it's usually
Yes,
in an acute environment where there's 15 medications being given in the hospital for a lot of things going on. It'll be the, I don't want to say good old fashioned, but it's the one that we all know of. The like quetiapine, the Haldol, the simple antibiotics, people forgetting, making sure that the electrolytes are really ultra conservatively managed. So it's the usual suspects, I think.
So exactly the question which came up meantime was about potential exposure if somebody, let's say, is treated for COVID and prevented by vaccination. So Zithromax, azithromycin is probably the most of concern, assuming that quinons will not be used. So hopefully patients who happen to be affected won't be treated with Zithromax.
Right, and it's always a balance of risk and benefit.
Yeah.
Okay, great. I don't see any other questions, so we'll move on to the next speaker. Thank you again, Spencer, for the great and comprehensive talk. And I'm really happy to present our next speaker, Dr. Awa Yunus, who has been working with us for more than a year, and he has done very innovative research, and he's also now got awarded the AHA Fellow on research on sudden cardiac death and sex-specific cardiac death. And actually the topic of this talk is going to be female hormones, cardiac arrhythmias, and long QT syndrome for menarche through pregnancy, postpartum period, and menopause. So thank you, Yunus, for being with us, and the stage is yours.